Today is a special lecture. It's one of our named grand rounds, and it's named after Dr. John Sullivan, who was a beloved faculty member. And to start things off for this special lecture, I'm pleased to introduce Dr. Beth DeGrush. Dr. DeGrush is the Associate Training Director in the General Psychiatry Program and Training Director of the Combined Neurology and Psychiatry Training Program here at UMass. She is a graduate of the University of Rochester, the Chicago College of Osteopathic Medicine, and our own UMass Combined Neuropsychiatry Residency Program. She is board certified in both psychiatry and neurology and works at UMass Chan and Community Neuroscience Services in Westboro, an affiliated private neuropsychiatry practice. Dr. Grush's interests include dementia, mild traumatic brain injury, functional neurologic disorders, multiple sclerosis, and related inflammatory brain conditions, and neuropsychiatric education. Dr. DeGrush.
Thank you, and welcome everyone. So this is the third annual John F. Sullivan Memorial Lecture in Neuropsychiatry. The past 2 years, you've heard a little bit about John from Dr. Benjamin as his teacher and mentor, but today you're going to hear a little different perspective, as John was my chief resident the year that I started here at UMass as a lowly intern in neuropsychiatry. From the start, John was the most quintessential chief. He was warm, he was supportive, and remarkably steadfast with the most calming affect, really nothing. He was unflappable. I inherited his clinic panel and I thought, okay, we'll see what happens. Once I started meeting some of these patients in clinic, which are neuropsychiatric patients, I had a consummate panic that rose as I realized how complicated these patients really were, and the work that John was doing. So I called him late one night in that year, and we went through every single case. So thank you again to his family for letting him be on the phone late hours. And essentially, he humanized every single one for me. He would tell me who was the ham radio enthusiast, whose marriage was on the rocks, who was an artist who no longer could do their art. And he made the job doable, you know? Every single one of his patients loved and appreciated his care. And that created some pretty large shoes for me to fill. But, you know, with his help and support, it was doable. That was just the beginning of his mentorship to me, and one of many late night phone calls, I think. And he always had the most straightforward, intelligent, and direct answer to the most complex questions. So I greatly miss his friendship and his mentorship. After graduation, to tell you a little bit more about John, he worked at the Brigham for about 5 years before he realized how much he missed us here and came back. And he was a beloved teacher, attending and medical director on 8 East. In June of 2022, when we lost John to cancer, his wife, TC, who's here today, thank you, expressed John's wish that a memorial lectureship be created in his name. I am thrilled to announce that due to the generosity of John's family, friends, colleagues, people in this room today, the Sullivan Lectureship was able to reach $38,000 and will be endowed in perpetuity, but continues to need your all's support. So as we continue to raise funds for this, we hope to expand its impact and use this as a vehicle for neuropsychiatry education, which was John's wish. So I will just put in a little plug here to please consider donating to the Sullivan Memorial Lectureship. You can go to the website, the UMass Chem website, foundation, and you type that in, I believe, Sullivan Memorial Lectureship. So I do want to point out that not only at TC, but we have a number of family and friends of John here today. So I want you to welcome them warmly as we do here at UMass. And now I will pivot a little bit to introduce our speaker today, who does not need an introduction, but I am delighted to provide it just the same. Dr. Sheldon Benjamin, professor of psychiatry and neurology at UMass Chan. He I will fail to mention everything that he has done. I had to cut some things out, I will just say, but bear with me. He has been such a paragon here. He's been director of neuropsychiatry here at UMass since 1986. He served as interim chair of psychiatry from 2017 to 2020, and many of us remember that transition period of time, which was just really a great time, and he did a wonderful job. However, in addition, director of the UMass Chan Neuropsychiatry Fellowship from 1989 until 2024, the founding director of the Combined Neurology Psychiatry Residency Program from 1997 to 2020, now associate director and co-director of the UMass Chan Fellowship in Adult Neurodevelopmental Disabilities. It goes on. He served as vice chair for education and psychiatry from 2009 to 2024. He describes himself as a specialist in the evaluation of behavioral problems at the interface of psychiatry and neurology, which is, I think, the most succinct and beautiful way of describing what we do in neuropsychiatry. He has started what I'm going to call his formal gentle taper of retirement from UMass this month, and will be returning part-time next month to teach and precept the neuropsychiatry clinic, just to ensure none of us get any significant discontinuation symptoms from, going cold turkey here. So, Sheldon, I invite you now to come up and give the John F. Sullivan Memorial Neuropsychiatry Lectureship. We are really looking forward to this talk.
Just pop up on screen. All right, you're all set now.
Great. There, that picking up? Yeah. Thanks very much, Dr. DeGrush, for the generous introduction. And it's so wonderful to see the family and friends back for the third time, some of you for the first time. So wonderful to welcome you here again. And I just want to also comment, in case you're wondering, we have a number of alumni in the Tampa Bay area, and I've been in touch with them this morning, and seems like everybody got through last night. Okay. So if you know Dr. Marrero, she's my source, and everything's going okay down there. Well, it's really, really wonderful to speak in the memory of John, because obviously he was a student and became a colleague, and one of the probably, I don't want to diss anybody else, but probably the funniest neuropsychiatry resident we ever had. So, okay, this doesn't work. For some reason, this gave up the ghost. So it's a weird long title that we have today: Molecular Mimicry in the Mind, Limbic Encephalitis, Long COVID, and the Lessons of a Long Lost Malady. A few quick disclosures. I have a publishing company, Neuropsychiatric Education Publishing Company. It's been around now for more than 10 years. We're still hoping to break even. So that's not much of a conflict of interest, but nevertheless, I get no income from pharma or industry. As a director of the American Board of Psychiatry and Neurology, I do receive a small stipend from that. This is some pre-game notes before we actually get into things, a few definitions. First of all, we're going to be talking about autoimmunity, and I want to make sure everybody knows what we're talking about. And that's when your body makes an antibody to its own tissues. And it can cause all sorts of diseases. There's probably over 100 of them, but a few of the ones you've probably heard of are rheumatoid arthritis and systemic lupus, things like that. And of course, in neurology and psychiatry, we've been very involved with a condition called autoimmune encephalitis in the last 2007, since then. And there's a lot of others. So we're going to be putting a thought to put in the back of your mind is, are autoimmune mechanisms the cause of some psychiatric symptoms and syndromes? So we're going to be thinking about that. Second part of the pregame here is molecular mimicry, because we're going to be talking about that. This is not the talk yet. I'm just like pre-gaming here. So these are two examples, but the idea of molecular mimicry is that something you get exposed to, like a bacteria or a virus, causes your body to make antibodies. And a virus is composed of a bundle of little proteins that have little amino acids sticking out in different directions. Some of them are curled up and coiled, and some of them are just like a surface. And the antibodies are made to different parts of the virus. Sometimes some of the amino acids in a protein look just like a little coil of amino acids on a protein in a core part of your body. And your antibodies get confused and think it's a foreign agent. So by molecular mimicry, we mean that some foreign thing is mimicking an antigen, that is something that attracts an antibody, on one of your own tissues. And so an example on the left side is how plain old strep infections can cause rheumatic heart disease by causing antibodies that happen to react to a little protein sticking out of a little muscle on your heart, and gradually your body, having done the appropriate thing to respond to the strep, then does the inappropriate thing and treats your heart like a foreign agent. Well, the right side is about the brain, which is closer to what we're talking about today. And so that's a virus, the thing in the ball up there, virus ball. Is that mouse showing? No. And then what you're seeing there is a B cell that makes antibodies. It's part of our immune system. It makes antibodies to some of those coiled up things on the outside of the virus. And then the antibodies are released. And on the bottom, you see the brain with the main limbic memory center called the hippocampus that I've pulled out. And then what happens is these antibodies simultaneously will attack the virus, but also the things in the brain that look like the virus. And so that's what we're going to mean by molecular mimicry. Part 3 of the pregame, the great imitators. Thank you, ChatGPT and DALL-E, for creating some masked imitators for me. So in the history of medicine, we've used the term the great imitator for a number of diseases that all have in common that they manifest as things that look just like other medical conditions. So there's a number of medical great imitators like tuberculosis, but in neuropsychiatry, our history of great imitators begins with neurosyphilis. When it invaded the frontal lobes in tertiary syphilis, it used to be known as GPI, or general paresis of the insane, and all psychiatrists at the beginning of the 20th century could easily diagnose this and treat it. It was very, very well known, and it was responsible for about 12.5% of admissions to state hospitals, both here and in Europe, at the turn of the 20th century. So when it was treated, finally, it was the first deinstitutionalization in psychiatry. In the last few decades, we've talked about Lyme disease, especially in the Northeast, because it causes things that look like migraine and depression and a number of other things. It's a great imitator. But the one we're going to focus on today is called encephalitis lethargica. And encephalitis lethargica was also known as sleepy sickness, SLEEPY, not sleeping sickness, that was trypanosomiasis, but sleepy sickness. And it was an epidemic around the world from 1916 to 1927. And that's what we're going to be talking about. And that was just the pregame. Here's what we're going to be dealing with. I'm not going to say I'm going to answer these, but these are some questions we're going to consider for the next half hour or so. What are the similarities between this epidemic that we've all forgotten about from 1916 to 1927 and the current common condition called autoimmune encephalitis that Joseph Dalmau described in 2007? We're going to think about, are there similarities between the chronic sequelae of that sleepy sickness epidemic and what we're now dealing with that was named by a patient as long COVID? In the UK, they call it something else, but here it's long COVID. Are there symptoms of encephalitis lethargica that overlap with what we call chronic fatigue syndrome? Okay. And the other question which we'll raise and at least think about is what caused encephalitis lethargica, and how might molecular mimicry and autoimmunity play a role not only in understanding encephalitis lethargica, but understanding schizophrenia and other neuropsychiatric conditions. I'm going to try to do all that in the next half hour. So it's not, we'll get it. But I said consider, not answer. So Before we get into this, I want to show you what we're talking about. This is part of a documentary back in the the mid 80s. Oliver Sacks was very interested in encephalitis lethargica. Some of you might have seen the Hollywood movie Awakenings with Robert De Niro and Robin Williams playing Oliver Sacks. And that movie was based on films he made of his own patients in the Bronx at a nursing home, where a whole lot of people who survived the 1916 to 1927 encephalitis lethargic epidemic were in chronic care. And he began to sort of experiment by using a drug that we use for Parkinson's disease on these people who had encephalitic Parkinson's. And he made these videos. This is part of a 45-minute movie that was made for the BBC in 1973 and 4. This was the pre-internet era, also the pre-digital photography era. And when I saw Oliver present it for the first time, I saw him present it a few different times, I was very moved by the film and said, gee, could I have a copy of this to show our residents in Worcester? And he said, absolutely not. I'm the only one that can, this is before the internet. And then the thing was on a 16mm reel. And even then, in the mid 80s, those projectors were getting harder to get. I said, don't you want to have this on VHS? I said, if you give me the reel and let me put it on VHS, can I use it with the residents? He says, well, okay. So this is with permission of Sacks. So I've edited down to 3 minutes out of 45 minutes to give you an idea of what this was like. Hopefully the sound will work.
At 30, Lola was an active housewife. 6 years later, rigid and almost speechless in hospital, she wrote, I'm finished. There's nothing else to do.
I can't do my hands even. I can't do my hands.
Lillian has developed over 2,000 compulsive and elaborate tics. They come every afternoon, and each day they're different.
I can't do my hands even. I just spoke up, I can't do clear eating. Nose, my teeth not clear no more.
One night in 1926, Sylvia dreamed the world had come to a stop. She dreamed she was a living statue of stone. By morning, the nightmare had come true. Like Lola and Lillian, she was a victim of the strangest epidemic of our time. The first alarmist reports of the new disease came at the end of the Great War. All over the world, doctors were as baffled as the press. They named it sleepy sickness after its commonest symptom, a trance-like state which often overcame its victims for years. In Switzerland, a bride fell asleep at the altar. In France, not even childbirth could rouse one mother. As the epidemic spread, other symptoms multiplied. Parents were horrified to find their children's personalities changed overnight. Doctors reported schoolgirls becoming troublesome brawlers. One victim wrote, I feel certain that we have all been given another character and that our own died in our sleep. But the more seriously affected suffered only a short agony. Within a few weeks, patients could scarcely talk or swallow. They became emaciated and soon died. More than 1 million during the early 20s. No cure was ever found, and 50 years later, the disease still holds as many surprises as when it first appeared. It soon became obvious that sleepy sickness affected posture in a variety of ways. Often they seemed contradictory. Many patients had symptoms like those of Parkinson's disease, tremors and shaking of the limbs. Others were...
Oop, sorry, that's my fault. Didn't mean to do that. It's the desktop, right? Weird. There. And sorry about that. Yeah, let me see if I can get back to my slides here. They're in the
were
background.
caught or frozen in whatever position they were placed, immobile and statuesque. This condition, described as the rigidity of insanity, had previously only been found in schizophrenics and other deeply disturbed mental patients, and it seemed to support the view that these patients neither conveyed nor felt the feeling of life. They had become as passive as zombies. No two patients ever presented exactly the same picture. It seemed at first as though 1,000 different diseases had broken out.
So what was this? So this disease presented with a mild flu-like prodrome, and sometimes the patients didn't even remember having the mild flu-like prodrome. There were 3 different types of presentations that were described. The least common one was the hyperkinetic form, tended to be in younger people, where people would become acutely anxious, sometimes hypomanic and excited, and they were so-called driven, as in an organic driven state. And it was that organic driven state that gave way in Britain to the term minimal brain dysfunction, which we now know as attention deficit hyperactivity disorder, that was first described in the encephalitis folks. They would also get various kinds of movements and compulsions and things like that, and sleep disturbances that went on for months and months after recovery. They had some eye signs, some of them had seizures. Now, because of another project I was doing some years ago, I uncovered a film in Kentucky that was made at Worcester State Hospital in 1926 to 1929. My predecessor as training director, Spafford Ackerley, who was training director of the old Worcester State Hospital psychiatry residency from 26 to 30, made a training film. And he presented 13 different cases. It's silent movie. And in it, I found a case of a 5-year-old girl who had encephalitis lethargica and was admitted to Worcester State. So let me show you that. So first of all, I'll pause this so you can read his introduction, that she was 5 years old, had encephalitis lethargica, et cetera, psychosis, he says, and homicidality and suicidality. So that's kind of a striking diagnosis of a 5-year-old. And here she is. This was filmed at like what they called a pageant, the annual Worcester State Hospital pageant. And she never stopped. I just pulled this out a little bit of it, but she just, and she also was sort of vulgar for a 5-year-old as well. So anyway, the next most common, going in order of increasing commonness, was called the amyostatic akinetic form, and it presented acutely with after the sore throat with either sort of instant Parkinson disease or catatonia. And you saw some films of acutely catatonic, emaciated patients who were probably not going to live. Those films, you saw a guy in a white coat examining one of them, and that guy in the white coat we're going to talk about in a minute. His name was Konstantin von Economo, who the disease became named after. And so these people would get instantly rigid and akinetic, but they would also get psychomotor slowing. They would look very much like they were demented, but if you gave them time to respond, they actually were cognitively intact. And they had a pretty high likelihood of later in life having post-encephalitic Parkinson's disease. The most common form was the somnolent ophthalmoplegic form that gave rise to the name of the disorder, sleepy sickness. These people would, after the sore throat, if they had a sore throat, or remember that they would become drowsy, then sleepy, and then semi-comatose. And it would go on like that for weeks or even months, and in 1 or 2 reported cases, years. You could arouse them and get them to eat, and they go right back to sleep. You could arouse them and ask them to follow commands, and they would do it and go back to sleep. You saw in the video you saw a woman that said Santé, that was in Switzerland, I think. You saw a woman being examined who the doctor asked her to raise her hand. She put her hand up and went back to sleep again. So it was very striking. They would have either pupillary abnormality or at least some sort of an oculomotor paresis, at the same time. They would have nystagmus. They would sometimes have a weakness in the face, end up spastic, some of them ataxic, and some of them had Parkinsonism, some of them had movement disorder, some of them had catatonia. But these were the ones that had the highest likelihood of later in life having post-encephalitic Parkinson's. And oddly enough, this post-encephalitic Parkinson's could come on weeks, months later, but it could come on 20 years later. And when I first came to this department in 1986, I took over, I know this, people who are inpatient docs now don't recognize these numbers, but I took over a ward at Westboro State Hospital with 37 aggressive elderly males on it. And that was considered the caseload. Just for comparison, I know we have a couple of Worcester Recovery docs here. I was, for various reasons, was doing a thorough re-diagnosis of them. And as I went through, I found 2 out of my 37 were admitted with acute encephalitis lethargica in the 20s and were still in the hospital in the 1980s. Yeah. So what do we know about this disorder? Well, there's a big variability in the reports because there was no standard way of recording it or reporting it. There weren't diagnostic criteria, but it affected either from 500,000 to 5 million people around the world. Sachs believed 5 million, and that's why in the video I talked about 1 million people dying. It was not a reportable disease like syphilis, so the health departments didn't really have a record of it, and it wasn't tracked. 3/4 of the cases were fairly mild and not reported and didn't result in hospitalization. It affected all ages, but young adults were at the highest risk. And usually in an infection, elderly people are at the highest risk. But young adults were at the highest risk in this. And the highest mortality was between ages 20 and 40, which is not what you'd expect if it was, for instance, influenza. 40% would die, unfortunately, in the acute phase. 30% seemed to recover fully, and 30% had deficits or Parkinson's or somehow had long-term sequelae. If they got it in infancy, they ended up as intellectually disabled. If they got it in childhood, they ended up as personality disordered or having some big personality change. In adulthood, they would end up with either psychosis or encephalitic Parkinson's or both. And because there were inconsistent criteria, it's hard to make conclusions now, but doctors all around the world were diagnosing the same syndrome. So they did see things in common, but it was difficult to know whether they actually ruled out other neurologic possible causes. So, it's a little tricky to go back and reinterpret the literature. A lot of people have tried. Maybe there were coincident etiologies, but nevertheless, there's a lot of consistency in the literature. So this Parkinson disease that they got is different than the idiopathic Parkinson disease that we all know older people have now. It's different. It was the most common of the long-term sequelae, even if people didn't have the acute akinetic form, but a little bit different. There was insidious onset that could come on even years after the illness. I mentioned that. But it was, there's 3 big components of idiopathic Parkinson disease. What we call akinesia, not being able to move, rigidity, being stiff, and having a tremor, which classically is a 4 to 6 per second pill rolling tremor that looks like this. These people had the rigidity and the akinesia, but didn't have the tremor very much. And if they did have a tremor, sometimes it was a rubral tremor or a real coarse tremor that was a little, not what you'd expect in evolving Parkinson disease. But in addition, they had things that people with Parkinson disease don't normally have. They had concurrent hyperkinetic motor phenomena. They'd have tics. This is, by the way, where akathisia, the motor restlessness that we see with antipsychotics, was first described in encephalitis lethargica. They had dystonic spasms. The most common was ocular gyrate crisis, where the eyes would go up. They had stereotypies. They had echolalia, which is repeating what you've just heard. They had palilalia, which is repeating the end of the syllables, like that. They had all these motor and speech behaviors, compulsions, which you don't expect in Parkinson's. Some of them became paraphilics. Some of them had, up to 1/3 of them would have paranoia, hallucinations, bipolar moods. They had, when you looked at their brains, there was a massive loss of pigmented neurons. There were no Lewy body inclusions, the classic inclusions you look for in idiopathic Parkinson's disease inside the neuronal cytoplasm. There was a narrowed therapeutic window to L-DOPA, which Sachs found and they highlighted in the movie Awakenings, meaning it takes a lot of drug to get any improvement, but a lot of drug plus a few milligrams causes side effects. That's what we mean by a narrow therapeutic window. So I've got another film here from the days, from the 20s. And this fellow has what's called festination and camptocormia. So camptocormia is being bent over all the way. Festinating gait is due to impaired postural reflexes that makes you kind of fall forward or backward. In this case, it's an interesting one, going backward. And combined with the Parkinsonian gait, which is called marche à petits pas, tiny steps. So you have tiny steps falling forward, and that's what you were seeing there. And the people were trying to catch up to them and grab them. In the aftermath of post-encephalitic Parkinsonism, every one of these psychiatric disorders was described in these patients. But it was due to brain disease. Many of these are things that we have no cause for. Schizophrenia, bipolar, catatonia, obsessive compulsive disorder, all of these things were described. So this was truly a psychiatric pandemic. People came down with all of these things from 1927, the end of the epidemic, up till around 1948, 1950. They were still coming down with these things. And sometimes it was forgotten in the charts, like in the ones I had at Westboro. So what does it take to have a disease named after you? I wondered this, right? So Konstantin von Economo, whose name became associated with this, it's von Economo's disease is the other name, was a psychiatrist and a neuropathologist. And neurology wasn't as well established in the late 19th century, but he also did neurologic consults. In Vienna, worked at a military hospital after he came back from serving in World War I. And he was the first one to report this disease in 1916. And he called it encephalitis lethargica because of the sleepiness. Gave detailed descriptions, described the main forms of it, and people were sending him brains to study from all around the world because he was known as a good neuropathologist and had been very interested in this condition. And also people were being transferred to Vienna from around Europe for his diagnosis. He saw a lot of patients with this. And somewhat to the surprise of doctors around the world, because when you have something that's been called encephalitis and you come down with a behavior change, naturally everybody assumes the pathology is in the cortex, where behavior is, right? It's going to be in the frontal lobes or it's going to be in the temporal lobes. But he did careful brain cuttings and he showed the pathology, inflammatory infiltrates, were in the midbrain, in the brainstem. What? The brainstem can cause psychiatric disease? He was the first one to propose this. And he also then began to track the disease. And gradually, after it presented in Vienna in the spring of 16 and then the early part of 17, it started popping up in other countries. And sometimes when it popped up in another country, it looked a little bit different. So what, if it was the same syndrome in general, but there were differences in the reporting. And so von Economo thought that this sounded familiar, this idea of having a febrile illness with eye movement problems and sleepiness followed by neuropsychiatric sequelae. And he asked his mom, didn't you once say that there was a flu in Italy in 1889 that sounded something like this? It was the Italian nona. And in fact, it's one of about a dozen known epidemics in Europe that we know about that go back to the 1600s that included either a fever or low-grade flu symptoms followed by sleepiness, eye movement abnormalities, and psychiatric phenomena. So because he remembered that, he went on to make the connections between these because of his mother's memory, I guess. So we actually have the first case report. Here it is. Johannes Peter Albrecht of Hildesheim in 1629 published the first case of this. And my Latin's not great, but it's de febra lethargica in strabismum utrisk oculi descendenti, which is lethargic fever resulting in bilateral ocular strabismus. So it sounds like the same disorder. Von Economo was born in Romania, raised in Trieste, Austria-Hungary. He spoke a lot of languages. He had an Italian nanny, and she taught him Italian, and he spoke French, German, Greek. He, at the age of 14, read Cesare Lombroso's Genio e Folia, the treatise on genius and madness. Lombroso believed that people with mental illness, or people that were geniuses, were much more likely to have mental illness. And he published this. It very much impressed this 14-year-old. He said, I'm going to become a doctor. So he studied mechanical engineering because his father didn't want him to become a doctor. His father wanted him to have something you could make money at. And after 2 years, he transferred to medical school in Vienna at age 18. And after medical school, he designed his own, they didn't have residencies then, but his own apprenticeships. Did pretty well for himself. He studied neurology, histology, psychiatry, hypnosis, microscopy, neuronal structure. And he did this under Pierre Marie, under Emil Kraepelin, under Alois Alzheimer, and just about every famous neurologist in Europe at that time. He studied medicine under Nothnagel, who was the first to study something like atrial fibrillation, I think. So, and then he joined Julius Wagner Joreg's lab in Vienna in 1906. But this was an interesting guy. It's worth knowing that sometimes the people who have eponyms, there's a movement in medicine to get rid of eponyms and call everything by some other scientific name. It's so hard for me when I learn about these people who describe these diseases and what they were like to hear that we're not allowed to say their names anymore. But in I think it was 1907, the Wright brothers flew. Von Economo heard about this and said, I want to fly. And of course, in Austria, you couldn't fly. But in Paris, they were at least training people how to fly balloons. So he went to Paris in 1907, got an aeronautics license and flew a balloon back to Austria. And then he got the first airline pilot license 001 in Austria. He had the first privately owned plane in Austria. Every morning before he'd go to the neurology clinic, he would fly for 2 hours in the morning to take a look at the countryside. He designed Austria's first airport. He promoted plane manufacture and convinced Austria to use airplanes in World War I. Here you've got a picture. This is actually a picture of von Economo flying his plane in the early 20th century. There he is. And this is Emperor Franz Joseph, who is coming to greet von Economo at the airport before he takes off, because he convinced Franz Joseph about the importance of investing in air. But he had a number of other things to contribute in his legacy. First of all, of course, he described encephalitis lethargica, but he also felt that the cortical maps of the day were not adequate. And in neurology, we know about Brodmann's areas and how many of them there are. But he designed a much more detailed cortical map and published it. Had 150 some areas that were they were according to their cellular structure. He also postulated that there is a sleep center in the brainstem, and it is in fact where we think the sleep center is today. He described a new kind of neuron, which we now call a von Economo neuron, a bipolar neuron in the anterior cingulate cortex and the insula that we think are important in social behavior and mental illness. And he said, and there's a stamp from Austria that they issued with his picture on it. And every psychologist who in the future attempts to deal with, these things that psychologists deal with who don't know about the observations on encephalitic patients will build on sand, he said. So was it a virus? Well, there were old areas of perivenular inflammatory infiltrates, and there were also some new areas, sometimes in the cortex, of new inflammatory infiltrates. Maybe the disease had been reactivated in some of the people he studied that died later. It partially, but not completely, overlapped the Spanish flu. This started 2 years before the first report of the great Spanish flu epidemic. They actually found 8 bodies that were frozen from the days of encephalitis lethargica, and from the brains got specimens and did PCR analysis and found no viral evidence of any genes from influenza. So we know that they weren't in those people. Also, it didn't spread in families. It was a flu. You'd expect that families would get it. And also the peak incidence is young adulthood. Why not in the elderly? So was it an autoimmune disease? Well, there were in 2004 a report of 20 new cases of something like this that all had that half of them had anti-basal ganglia antibodies. Also, we know that people with strep can get a thing called Sydenham's chorea due to an autoimmune response to the strep, and Pandas syndrome is speculated to be that. Lethargica-like syndromes have been reported in some of the patients with strep. Also, there's a case report of steroid-responsive lethargical-like syndrome. So that means that at least there was immune involvement in that case. When you tap those patients, do see cerebral spinal fluid studies, you find oligoclonal bands, which means there's an immune response going on. And there have been people with disorders that sound like encephalitis lethargica that have anti-NMDA receptor antibodies in them. And on MRI, occasionally you see basal ganglia lesions that look a little bit like the white matter going to the basal ganglia looks a little dysmyelinated. So I don't know. Here is Susanna Cahalan. You might remember that we had her as a visiting professor here a few years ago. She wrote a very interesting book called Brain on Fire about her bout with autoimmune encephalitis. And she became manic during her bout and developed seizures. So autoimmune encephalitis, the possible kind, where we're always thinking about it in psychiatric patients, is subacute, means it should be less than 3 months since it started. It should involve short-term memory loss, usually some sort of mental status changes or psychiatric symptoms, and at least one of either a focal finding on neurologic exam or seizures without previously known seizures, CSF abnormalities that we call pleocytosis in the spinal fluid, and on MRI, little hyperintensities in the medial temporal lobes on FLAIR images, and reasonably excluding other causes. These are the MRI abnormalities that we typically see in this condition. So autoimmune encephalitis has a little bit of a sore throat or a mild URI prodrome, subacute onset, movement disorders, autonomic dysfunction frequently with varying blood pressure and pulse. You can develop catatonia. There's a sleep disturbance often. There's multiple phenotypes in addition to the seizures, memory loss, and delirium. Encephalitis lethargica has those things, but also Parkinsonism, compulsions, oculomotor signs. They had quite a bit in common. Let's think about long COVID. In UK, it's called the post-COVID-19 syndrome. Here it's long COVID. Probably you know people with it because at least 10% of people who have COVID end up with some sort of symptoms that last weeks to months, if not longer than that. Usually it's more common to get in people who had a severe respiratory form of COVID, who are hospitalized more so than non-hospitalized. But since most COVID is not hospitalized, it turns out that most of the cases of long COVID follow non-hospitalized. It's just that it's more common to get it if you're hospitalized, but most cases that are reported follow non-hospitalized mild cases. And it affects everything. If you talk to people with long COVID, some of them, have headaches and dizziness, but others have nausea and irritable bowel syndrome, diarrhea. Others have palpitations and cardiac symptoms. Others have swelling and their muscles hurt. It has like 30 different possible symptoms that people have reported. Each case looks a little different. That's sort of like the terminology from encephalitis lethargica. What's it due to? Well, maybe there's, say, viral reservoirs have been suspended in tissues that are getting reactivated. Maybe the people have a hyperimmune state, which would account for them sort of antibodies attacking all over the body. Maybe it's some sort of anti-neuronal antibodies in the neuropsychiatric ones, similar to the story with strep. Maybe it's disease reactivation, but it might be molecular mimicry. We know there's a bidirectional relationship with autoimmune disease. People with pre-existing autoimmune diseases are more likely to end up with long COVID. People with long COVID are more likely to later be diagnosed with an autoimmune disease from the early studies that are mostly coming from Europe. But there's another condition that we see fairly often, chronic fatigue syndrome. precipitated by an infection, includes fatigue, something that long COVID people call brain fog. It includes headache, myalgias, and something called post-exertional malaise, which is not just being tired after working out. It's like the condition comes back after working out with all these other things. Sleep is no longer refreshing. They can have autonomic symptoms, GI symptoms, urinary symptoms, lung symptoms. Long COVID people have a higher incidence of like blood clots, pulmonary embolism, stroke, irritable bowel syndrome, memory problems, tinnitus, cough, menstrual symptoms, but a lot of them have all of the symptoms of chronic fatigue syndrome within their long COVID. And to complicate matters more, functional neurological disorder overlaps strongly with chronic fatigue syndrome and long COVID. Let's make the picture more complicated. On the left is a map of the 4 different ways that multiple sclerosis typically progresses. It's either the top picture this is a graph of disability on the vertical axis with time on the horizontal axis. And the top one is progressive relapsing MS, where you are both kind of going down in function and every now and then have an exacerbation. We get a little bit better, but keep going down in function. Secondary progressive, well, you're having relapses, remissions, and then you start to go down and function more steadily. Primary progressive is not a relapsing remitting condition. From the very beginning, it starts to get worse and worse and worse. And relapsing remitting, you get a break, you get a exacerbation, and you get pretty good afterwards. Not all the way better, but pretty good. And those could happen 10 years apart, 20 years apart, 1 year apart. So schizophrenia, if you think about it, can look exactly like this. Some people with schizophrenia from day one begin going downhill and end up in the residual state within a few years. It's not just something that happens after 25 years in the hospital or something like that. Some people with schizophrenia have an exacerbation, remission, do pretty well. Maybe 10 years later, have another exacerbation, do pretty well, but they're going downhill slowly. Some have a secondary progressive, and some have this progressive relapsing pattern where they come in every year or so into the hospital and they leave maybe a little bit worse than they were before. Young adult onset, of course. And there seems to be a pattern that's consistent with maternal infection predisposing the babies to growing up to have schizophrenia. There's a time of year that has to do with when viruses are prominent, et cetera. Having siblings a few years older seems to predict it. There's up to 30% monozygotic twin concordance. Older parental age, more in urban environments. But the lifetime prevalence of autoimmune disease is 50% higher in people with schizophrenia than in the general population. People with autoimmune diseases have a 45% higher risk of developing schizophrenia than the general population. You can measure increased cytokine activity, part of the inflammation system, in people with schizophrenia. There's an antibody, there's an antigen called neural cell adhesion molecule, which is an IgG that's important in neural development. And you can see increased antibodies to that in people with schizophrenia. And the most prominent genetic risk loci, of which there are over 200 or 250 identified now, the most prominent ones, the one that account for the most variance, are the ones that have to do with genes for the inflammation immune system, cytokines and C4 and all that. There are cases of brain-reactive antibodies being found. And of course, we know that when you get autoimmune encephalitis, like in brain on fire, at least during the acute phase, you can look very much like you have a serious psychotic illness. Also, gut dysbiosis, that is, abnormalities of gut flora, have been described in schizophrenia. There's a big literature on that now. But that is one of the things that can lead to hyperimmune conditions as well. So what did we learn from this long-lost malady? Well, back in the day, a lot of the psychiatric symptoms were described as functional. Hysterical, conversion, whatever. But what appears functional today may not be tomorrow. Also, behavioral sequelae are not limited to cortical damage. This was a brainstem encephalitis. Most interestingly, behavioral sequelae can have a delayed onset. We know from the twin studies that if you look at the MRIs of identical twins, one of whom goes on to have schizophrenia, one of whom does not, this is Danny Weinberger and Fuller Torrey's famous research from the NIMH, that that you can have the atrophy in the brain present, but not show any signs of the disorder for 5, 10, 15, 20 years. Meaning you could have a delayed onset even though the brain damage is there. We also learned that motion and emotion are inseparable traveling companions. Movement disorders and mental illness, movement disorders and cognitive disorders, and that infection and autoimmunity may be important mechanisms in neuropsychiatry. Here's a quote from Konstantin von Economo looking back at the epidemic in his book. Just as we find it hard today to follow up the trend of thought, as in what were they thinking of our scientific predecessors for whom bacteriology and the lore of brain localization didn't exist, future generations, that's us, will hardly be able to appreciate our pre-encephalitic neurologic and psychiatric conceptions, particularly with regard to so-called functional disturbances. I was not taught about encephalitis lethargica in medical school. Psychiatry forgot this disorder, and they were very surprised when Joe Dalbau discovered the antibodies to a disorder that probably would have been described earlier had people remembered this condition. So in summary, encephalitis lethargica may have been an autoimmune disease with different manifestations due to molecular mimicry, maybe. Long COVID can have a lot of different symptoms. We don't know what it is. Remains a mystery, but it could be consistent with a hyperimmune response and maybe disease reactivation. Chronic fatigue syndrome, long COVID, encephalitis lethargica, and even the common post-influenza syndromes that a lot of people have where they're logy and headachy and muscle aches that go on for weeks. All of these share a number of characteristics. We don't know the etiology of any of these conditions for sure, but inflammation, autoimmunity, molecular mimicry, some combination of genetic risk factors and precipitant factors are likely relevant to these syndromes and to schizophrenia. So in summary, we don't know. I mean, if I remember, like if I were John Sullivan and I was going to raise my hand and ask a question after this lecture, he would say something like, so after this hour, you really don't know, do you? I said, nope. I really don't know. Anyway, I want to thank John's family, and friends for endowing this, and look forward to having a few minutes here to interact with questions.
We'll begin with questions in the room. Sorry.
I just want to make the point.
The microphone is because it's being broadcast on Zoom, so we want everybody to hear the questions.
I just want to make the point that that sense of humor of John's that you talked about was with him from the moment he was born. He entertained me forever.
Thank you. Anyone else? Yes. Okay.
Dr. Silver.
Thanks. That was a great talk. The first time I heard about von Economos was rounding with Jane Sargent in the early 1990s. And so we had a young female patient who was a nurse who had suddenly had an abrupt change in her mental status. So she was Parkinsonian, sitting on the ground. And Jane said, you know, if we were around 70 years ago, this patient would have been called von Economos. And I'm like, oh, that's interesting. I don't know what this is, but whatever. Okay, so, but anyway, long story short, we did a bunch of stuff, brain biopsy, nothing was positive. And we decided to just put her on steroids. And nothing happened in the hospital, but then I saw her in clinic a year later, and she was totally back to normal. No Parkinsonian features, no psychosis, none of that. It was just remarkable. So that's stuck with me. And I guess the question I have is whether you're aware of any literature in people who are exposed to steroids, which I know can cause psychosis itself, whether that diminishes the risk of developing this condition.
Ooh, I didn't know you were going to talk about diminishing the risk of developing it. I have no idea. But I will say that one difference between early 1990s and now is Dalma went on to describe, I don't know how many more antibodies, but if you now look at the list of paraneoplastic and non-paraneoplastic autoantibodies, there's a huge list of them, and we didn't know about them in the 90s. So, and that would have gotten better with steroids. So that may be. The other thing I'm going to say is that before Dalmau described this condition, autoimmune encephalitis, we always saw people with catatonia here in the hospital. And sometimes they had a particularly malignant kind that we used to call, unfortunately, we used to call it lethal catatonia, because their blood pressure and heart rate were going through the roof. They were getting febrile. They had to be in the ICU. And we treated them acutely with electroconvulsive therapy. And they got better. Maybe the next year they had a problem again. I don't know. But they did get better. And these are some of the same people that after 2007, we learned were autoimmune encephalitis. Some of them had to have an ovary removed because of a tumor, but a lot didn't have tumors. And they got better with steroids and with rituximab and different things like that. So, yeah.
So thank you. That was wonderful. I just want to make a couple of comments. The little girl who you showed, she looked like she had hyperactive catatonia. So I would put her in the bucket of catatonic as well.
Maybe.
And the other, we used to see this on the consult service, other than the sort of antibodies against glutamate, et cetera. A biggie are the spirochetes, Lyme, babesiosis in particular, that goes right for the CNS. And it puts people in the ICU, and it's responsive to steroids. So that's a very sort of more modern version of this before we had COVID.
Right. And it's actually fairly common to test for Lyme here, but not as common to test for some of the other, just test with ELISA for some of the others. Yeah.
Russia has, there are all of these variants that we
Yeah.
don't even have antibodies for.
That's true. And back, if you were a psychiatrist at one of the state hospitals prior to 1927 or so, you would have been very expert in diagnosing neurosyphilis. And if you look at the old Worcester State Hospital annual reports, which are available through our library heritage collection, you can look at the number for each year that were admitted and that autopsies were done, et cetera. The guy who did a lot of the neurofibrillary tangle work for Alois Alzheimer in 1906, who came from Westboro State Hospital and went over there, he also published a lot of autopsy reports of neurosyphilis. They studied it very carefully. Some of them were called syphilologists. Psychiatrists were expert on those diseases. Yeah.
Dr. Sattel.
And I'll use the...
Thank you. First of all, you stole my thunder because I was going to ask about paraneoplastic limbic encephalitis and how we get into this. But I've also had the experience of treating patients with malignant catatonia with ECT and could tell a lot of story. Well, there were a number of them back in the 1990s when I was the primary person doing ECT here. And I can remember one patient in particular who was a young woman who actually required, I think, something like 30 ECT treatments. And I was at the point of literally being afraid each time I did it about what was going to happen long-term for her, but she got better.
I remember that. Is this the one who sent us the picture from her prom?
Yes. Yes.
Yeah, this is a young woman who was extremely ill. And I think you had to, you might have even come in on a weekend to start her ECT.
Saturday ECT,
yeah,
5 days a week, sometimes 6 days a week.
It took a few weeks. She finally, I remember I paid her $1 to let me examine her.
Gosh.
Because she didn't want me to examine her, and she did it for $1. And then we got a picture back that she got better. She went to her prom, and it showed her in the limo, or getting into the limo with her date. And her mother was over the moon. I remember that case.
Yeah, I'm having flashbacks.
Yeah.
I remember her initials. But no, thank you very much for this wonderful presentation. I'm sorry I missed the first half of it, but wow.
Yeah.
Thank you.
Oh, online? I'm sorry. Are there?
A couple of questions about treatment. What would you recommend for treatment of long COVID? You already addressed the steroids, other immunosuppressant therapies.
Yeah, I'm not an expert on long COVID. However, I did read quite a bit about it in the last few months. And it looks to me like, even though there are people trying all sorts of things, it looks to me like these basic things like exercise and diet and avoiding like stimulants and alcohol and stuff like that seems to help some people. There are some experiments going on, I think, with immune treatments, but I don't think they're there yet. So I wouldn't know what to recommend other than rest and eat well and exercise. Maybe see a physical therapist, but I don't know. It's too soon.
We have time for one more. There's a medical student in Zoomland who's having a flashback to a lecture you gave on OCD and Tourette's. Are there any historical observations suggesting a link between EL and subsequent development of tic disorders and OCD?
That's an excellent question. In fact, in 1938, there was a psychiatrist named Leo Schilder who had been very impressed with all the people with post-encephalitic Parkinsonism who got OCD and studied them and looked at their first-degree relatives and looked at people with regular OCD that didn't have encephalitis lethargica and found that people with regular OCD had, I forget the percentage, but a much higher chance of having immediate relatives, first-degree relatives with tics. People with encephalitis lethargica had a huge, 30% of the people with encephalitic Parkinson's and psychiatric problems had some sort of an obsessive compulsive symptom as well. So yes, that's a connection. But in addition, we learned from this to look at the patients with OCD and their immediate family for things like tics. And in people with Tourette syndrome, their immediate family might have a higher incidence of OCD as well. So it's kind of interesting.
One last question about autism.
Uh-oh.
What about autism and autoimmunity?
Well, there is a connection, but I don't know that it explains autism. But in 1981, I remember the first paper I ever saw on reversible, I think it was reversible autism or something. It was clearly somebody with something that sounded very much like autoimmune encephalitis that presented as acute autism and did get better. But I don't know about any connection with modern autism. Dr. Cochran does.
All right. Well,
he says, nope, don't ask me. Pass on that.
Thank you very much. It was interesting.
Thank you.